I want to introduce to you Dr. Stewart. Dr. Stewart received his medical degree from the University of Minnesota School of Medicine and completed his orthopedic surgery residency at Mayo Clinic, Rochester, Minnesota in 1997. Prior to joining Chippewa Valley Orthopedics, Dr. Stewart had been a practicing orthopedic surgeon at Northern Arizona Orthopedics in Flagstaff, Arizona. Tonight, he is going to speak on reducing risks in total joint arthroplasty. So welcome, Dr. Stewart.
And thank you for the kind introduction. As stated, I'm Dr. Stewart. I actually work next door. Many of you have seen the Chippewa Valley Orthopedics office. It's right next to Oakleaf here. And I also want to thank my colleague, Kate Nelson. She's a PA who works with me, helped tremendously with this talk. So she helped put the talk together and has been instrumental in implementing some of these ideas and turning these ideas into practice in our practice so that patients have a safer arthroplasty, a better hip or knee replacement. So I started in arthroplasty business in 1992. At that time, our main concern was, can we do arthroplasty in a way that's durable? And if you went to a meeting about hip or knee replacements in 1992, all the talks were about how long can these implants last. So we wanted implants that were going to last a long time. Somewhere about 10, 15 years ago, we started being very concerned with how can we make the experience less difficult? How can patients have less pain, faster recovery? And that was really the emphasis. Well, if you went to a meeting in orthopedics in the last 3 or 4 years, really risk reduction has become one of the main topics that you'll see at any orthopedic conference, because we've gone from kind of an individual surgeon to more of a system and a checklist approach where we want to be like the airline industry. No failures are acceptable. So to do that, it's not just relying on one person's skill and one person's energy, but we're going to put in place systems, checklists, plans that make things as safe as possible. And we want to have zero problems if possible. So the outline of the talk, first we're going to talk about what are the risks. So if you've had friends who've had arthroplasty, if you talk to enough people, you've heard people who've had problems with their arthroplasty. We're going to talk about what those problems can be, and they can be serious. We're going to talk about what modifiable risk factors are. That is, what things can we change before surgery so that your surgery is likely to go well and that you're likely to avoid complication. We're going to talk about what we do intraoperatively to reduce complications, so the things we do in the operating room, we do in surgery to reduce complications. And they'll talk about things we do post-operatively so you don't have a problem. There's no doubt that elective joint replacement can have a profound effect on a person's life. So it's sounding dramatic here, but it's almost like biblical work, helping the lame to walk. But when it goes wrong, it's very human. So we want to be able to achieve those great results with the least risk to the person. Complications have an enormous emotional and physical toll on the patient, and then even the hospital systems and society as a group. So we want to minimize them for all those reasons. We want to do everything we possibly can to make sure your surgery goes well, and we've developed guidelines that have been based on the data published over the last several years to help surgery go safer and make it more effective. And we take these things very seriously because the outcomes and your health is a serious topic. So what are the risks of undergoing total joint arthroplasty? We like to look at our own data. So occasionally we'll review our results, or we'll have an outside reviewer come and review our results. Basically, for a large-scale joint replacement surgery in my practice, we have about a 2% chance of something happening that's untoward. So that's our data. The things we worry about are infection, a blood clot, that's a deep blood clot deep in the veins that can then go from the veins of your legs up to your lungs, which is then called a pulmonary embolism. Something like a wound healing problem. Things like a reaction to anesthesia. This is something people think about a lot, like you're going to have anesthesia and you're going to have a heart attack or a stroke or something during surgery. That almost never happens. Now, that's important, but that's almost unheard of. It's really these top three that are problematic. So when we looked at the first 700 hips we did from the anterior approach, so that's a group of patients we recently reviewed, we had about a 1.1% chance of infection in that and a 0.4% chance of a deep venous thrombosis, so a low complication rate there. If you look at national data, the infection rates are around 2%, and DVTs or blood clots are around 3%, and getting a pulmonary embolus is up as high as 1.5%. So we have a reduced risk compared to published national data, and those are our own patients. The last 700 we did anteriorly for the hip. what does an infection look like? You can see on the slide on the right here, on your right, this is a patient who's had a knee replacement. That's their incision where we went in to do the knee replacement. And the redness and the inflammation around the knee, that's a sign of infection. So depending on how quickly we determine you have a complication, that determines how it's going to be treated and the depth of the infection. So if you're very fortunate and you are unfortunate but only get a superficial infection, we can treat that with oral antibiotics, but that's the minority of cases. If the infection is deep, it's much more serious. If the infection is beyond the skin and deeper into the knee, then you're going to require more surgery. Typically, if we catch it early, like we see the infection within a few days or a week, we can go in and clean the infection out and keep your joint replacement in place. But if the infection is they're really well established and kind of built up in there, we have to actually take the implant out. So you had your knee surgery or your hip surgery, the infection became established, and we have to remove that implant until the infection is gone. So a slide on your right there is an example of a knee replacement after it's been put in and we're opening it back up. And if the infection is really well established, all the parts that we put in initially have to be removed. So we can get rid of the infection. When the implant is gone, we put a temporary spacer, but it's not like a real implant. That's sort of a poor excuse for a knee or a poor excuse for hip, and that stays in place until the infection's cured. When the infection is cured, we can go back and put in an implant that works better. After we put the new implant in, so 6 weeks later, up to 12 weeks later, you may have to take an antibiotic pill for the rest of your life to try to prevent the infection from coming back in that newer joint that we put in. So the details of that are probably less important than you remember, but just knowing an infection is a really big problem, right? It's something that requires a lot of further treatment. Some of that treatment may be at home, but some of it may be in a nursing home. So certainly something we want to avoid. I think that this slide and this talk is important because in the office, we can tell you that this is a risk, but you have no idea, right? You've never seen it, you've never experienced it. I think it's hard for us as physicians to impart that information to patients, especially in the time we're allotted with each individual patient from room to room. But just need to know it's a serious complication with long-term consequences. A blood clot, this is probably the most serious thing that can happen to you in terms of potentially fatal, though very, very rare. The slide on your right is an example of lungs that have had a blood clot, and they're trying to blow that up. A blood clot's gone from your legs, up through your veins, through your heart, and out to your lungs, and it can damage part of the lung. That's called a pulmonary embolus. So if you get a blood clot in the deep veins of your legs or your pelvis, it can transfer up into your lungs, and that can cause damage to your lungs. This slide shows a small area. This person would have a little bit of trouble breathing, but not much. Their oxygen would be fine. They'd have some symptoms, but that size blood clot, that size damage to the lung wouldn't cause a big problem. But unfortunately, not all blood clots are that size. Sometimes they're much larger and can be a serious concern. So the blood clot in the leg is a problem, but the blood clot that goes to the lung is the more serious problem. So what's the crux of this talk is we're talking about risk abatement, doing things to make your risk lower. And we do this by every patient who signs up for surgery, we go through a checklist to see what potential factors you might have as an individual that make you at increased risk for surgery. And we divide up those factors into modifiable risk factors, things that we can change. So we're going to talk to you about how we can change those. We also look at non-modifiable risk factors. And then once these are identified, we work with you to make sure these things get corrected before you go ahead with surgery. The old model, and the model in still a lot of places, is your doctor decides you should have surgery. They send you to your internist, whose concern is primarily, are you going to survive the surgery? Well, fortunately, almost everybody survives the surgery. So they say, well, you're okay for surgery. You're going to make it. But they don't really say, are you in the best shape possible for surgery? Is there anything we could do for this surgery that could be delayed to make your surgery safer and make the outcomes better? And that's what we're doing. We're transitioning from can you make it through the surgery to can you be in the best possible condition for the surgery? And like we talked about earlier, we're trying to have the same standards as the airline industry. No complications are acceptable to us. And that's why we take these risk factors so seriously. We talk modifiable, non-modifiable risk factors. The modifiable risk factors, and these include smoking, diabetes that's poorly controlled, hepatitis C, something called MRSA, excessive alcohol use, morbid obesity, narcotic use, and dental hygiene. So if we identify these as problems, these are things that we can change. Things that are non-modifiable risk factors but change in the way in which we might treat you include things like a personal or family history of blood clot, a history of heart attack or a stroke, severe physical deconditioning, or being at a high fall risk, either from deconditioning or from like a neurological disease. Surgical risk abatement, and smoking. So if you had come to see me 5 years ago, I've told you that smoking was a bad idea, and it probably made your surgery a little bit worse, but I would have had no idea how bad it is. So data has come out in the last several years where we can quantify this. So if you're a smoker, you have a 2-time increased risk of developing infection. Not 10% more, not 20% more, not a little bit worse, but twice as likely to get an infection. Fortunately, if you stop smoking, 3 or 4 weeks later, you can heal up your incision just as well as somebody who doesn't smoke. If we look at the risk for readmission, so this is if you have a total hip, there's a chance you might have to go back to the hospital for any variety of reasons, whether it's a bladder infection or a problem with an infection in the joint or some other problem. Your chance of going back to the hospital and being readmitted after joint replacement surgery, if you're a smoker, is 5 times higher. Again, not a little bit higher, not slightly worse, but dramatically worse. So this is data that we didn't even have 5 years ago. So we require patients to quit smoking prior to the joint replacement. We can help patients by providing a prescription for Chantix, referring them to their primary care doctor, and we follow up on your progress. It's not enough to just tell you need to do this, but we check to make sure that you have and that if there's anything we can do to help. Diabetes, these are kind of busy numbers, but basically diabetics have roughly twice the chance of getting an infection as someone who's non-diabetic. And so diabetes is a risk factor. Now, you can't become undiabetic, but you can manage your diabetes in such a way that your risk is reduced. And the best way to look at your risk is on something called your hemoglobin A1C. So if anyone here is diabetic, you know this is a number that they measure, and it measures your glucose control, not at that moment, but your glucose control over the last 120 days. So we have an idea of how well you've been doing with your diabetes over the last 3 months when you take that test. If you are over 8, we just feel that the surgery is too risky. Your chance of having a complication is too high. If you're under 7, you have almost a normal risk. Between 7 and 8 is kind of an area we're willing to compromise. If you've tried hard to manage your diabetes and your hemoglobin A1C is between 7 and 8, we will probably go ahead with the surgery knowing that we need to be especially careful with your glucose post-operatively. One thing that patients don't realize is if they're doing kind of okay with their diabetes, surgery throws kind of a loop towards you and it becomes harder to manage your diabetes afterwards. So if you're on the borderline of needing insulin, you've never taken insulin, when you have surgery you might need insulin for a week or 2. And it's definitely preferential if you're going to need insulin afterwards when you go home to learn how to do that before you're also trying to recover from your arthroplasty. So if you're borderline controlled with oral agents and you're going to have a major surgery and you're diabetic, you should probably take the opportunity to start learning to use insulin beforehand so you can manage yourself accurately and tightly after surgery. So that's a potential thing we can do ahead of time to make surgery better. Hepatitis C, this is an interesting case for me. When I was a medical student, we didn't even have it. We had non-A, non-B, and we didn't even know about hepatitis C. Hepatitis C was discovered. For a long time, it was incurable, right? There was no real effective treatments, and now it's entirely curable. So every patient who gets an arthroplasty through our practice gets screened for hepatitis C. If they are hepatitis C positive, they are sent for referral and they're cured, right? They're given the medications that get rid of it. The reason we do that is they're almost twice as likely to have a complication if they're untreated hepatitis C as opposed to having gotten rid of hepatitis C. So another thing we screen for. MRSA, some of you may have heard this before. You may not have heard the term MRSA, but you will have heard about bacteria that are resistant to antibiotics. So these are bacteria that when they see an antibiotic, it doesn't kill them, so they can keep living in the face of antibiotics. And they can be on your skin and you don't know it. So a person can be carrying MRSA on their skin and not even know that they have that. It's not causing a disease, it's not causing a problem. But when you go to have surgery, your risk of developing an infection is 6.3%. So that compares to our risk in our practice of 1%, so 6 times higher risk if you're a carrier of MRSA. What we do is screen every single patient for MRSA, and if they have that bacteria on their skin, we do a process called decolonization, which means they have special soaps and special treatments to get the bacteria off of their skin and change to a more normal type of bacteria on their skin so that when they have the arthroplasty, they don't get an infection. Another reason to do that is if you do get an infection, normally the infection you get comes from you, right? If you get an infection in your hip replacement or knee replacement, it's bacteria that were already on your body. And you don't want to get an infection with MRSA because we're going to have a hard time getting that out of your hip or out of your knee. And so doubly important. One, you're much more likely to get an infection if you have MRSA, and two, if you get an infection, it's going to be so much harder to treat. So we screen every single person for MRSA, and if it's present, we try to eradicate it. Alcohol use, consuming 2 to 3 drinks per day or more can suppress your immune system, affect your nutrition, and make you at higher risk for surgery. So you may have 2 or 3 drinks at times during the week, but I think it's probably even better to think of that as maybe 14 drinks a week is probably where it starts to be too many. Certainly we know that 7 drinks a week does not appear to be too many. And so if patients are drinking more than a couple of drinks per day on average, we ask them to cut that down. And typically that actually cures up pretty quickly. 3 or 4 weeks later, your general health can improve. You're just going to get rid of the effects of the alcohol. It doesn't take a long time. Now, if you're drinking a lot, 10, 12, 15 drinks a day, it may take longer for those effects to reverse. But for most people who are consuming a little bit too much, it doesn't take long for that effect to be reversed. And again, we counsel patients to do that prior to their surgery. This is probably the toughest topic of all. And that's people who are heavyset have an increased risk of complication after surgery. And we're not talking about sort of mildly heavyset. When you go to your doctor now, almost all of them are going to look at your weight, not just in how much you weigh, but how much you weigh versus how tall you are. And there's a ratio, that's what's the body mass index. So this means basically you take how much you weigh and you divide it by how tall you are using the metric system. And that gives you a number as to, we call it your BMI. So it's a way of looking at people and accounting for the fact that some people are taller than other people. If you look at the chart on your right, that's the BMI chart. A BMI of 30 is obese now, but we really don't see the big increase in complications until people get to a BMI of 40. So if people get to a BMI of 40, their risk of a joint infection is 3 times higher than people who are normal weight. So at 40, we start to see this inflection point where the risks go up. And if you get to a BMI of 50, your risk of infection is 21 times higher. It's like ridiculously high. So every gradation from 40 to 50 represents a substantial increase in risk. Now, it's also one of the hardest modifiable risk factors to modify, right? So for our practice, we have an absolute cutoff of 45. I just can't be talked into it over 45, no matter how long people have tried, because it's impossible for patients to know how much risk they're taking and for them to understand the complications. And those patients who are over 45 for BMI and have a complication, the surgery to eradicate the complication is difficult, but the postoperative care is really difficult. So they go to a nursing home and the people there aren't able to lift them. They aren't able to move them. They're literally kind of stuck in bed, unable to be cared for because they have this terrible infection and they're so large. So 45 is our absolute limit. We really want people to be under 40. A 3.3 times increased risk is not that great, right? It's still a pretty high risk. We understand the difficulty for people to lose weight, especially if they're having arthritic problems, but we have to set a limit, and that's currently our absolute hard stop is 45, with 40 being something we really would shoot for. We have a lot of time today, and this talk is only about 30 minutes long. More than an hour of time. I'm going to tell you a little vignette. When I started in this business here in town back in 2003, I was a lot younger. I was happy that I was really a hip expert, and I could do the surgery technically, even if a patient was really heavy set. So they might have seen somebody else in town and say, I just can't do your hip, man. You're just too big. And they'd come to me and I'm like, oh, I can do it. I'm strong enough. I have enough equipment. Technically, we can do the surgery, and we could. We could do the surgery well. I could get an X-ray after surgery. It would look perfect. But I was running increased risks I didn't even really understand at that time because we didn't have the data. During that time period, I had a guy come to me who had been told his problem was really his back. So he'd neglected his hips for a long time. He had serious hip arthritis. They hadn't made the diagnosis. And he says, I'm a single dad. I'm about to lose my job. If you don't do my hip surgery now, I'm going to lose my house. I'm going to lose my job. I'm going to lose custody of my son. You got to do my surgery. I can't lose weight. There's just no way. And I did the first hip like a dream. It's perfect. Went great. Did the second hip. Little spot didn't heal on the skin. We cleaned that up. That got an infection. Long story short, 9 surgeries later, I still don't have the infection out of his hip. So these complications are serious, and if we can do something to prevent them, we need to try to prevent them. narcotic use, this is an interesting thing because it's both a preoperative risk factor and a postoperative risk, right? So when we look at this, patients who are taking narcotics prior to their arthroplasty, they're more likely to get an infection, they're more likely to get a blood clot, they're more likely to have complications after surgery. So we want you to not be on narcotics before. But if you look at the national data, it's actually quite scary. This is actually the most common complication now after knee or hip replacement. Patients will get a knee or hip replacement, and 6 months later, 8.2% of knee replacement patients are still taking narcotics, and 3.4% of total hip patients are still taking narcotics 6 months later. And I can tell you, if you're still taking narcotics 6 months later, it's likely you're going to have a very hard time ever getting off the narcotics. So this is part of the opioid epidemic around the country. This is not at all reflective of our practice. We don't contribute to that. We don't give patients narcotics out that far. But if you look from the national data, that's now probably the biggest risk of somebody undergoing hip or knee replacement in the United States today. And along that line, to explain this to patients, we do this as a preoperative discussion so that postoperatively you know you're going to get a limited number of narcotics. I think many of you may have heard the expression, the man takes a drink, drink takes a drink, drink takes a man. If you start taking pain pills, you will think you need to take pain pills. And there'll become a point where you are convinced you absolutely need to take pain pills. And so we'll give you a limited number of pain pills after surgery. 20 for a hip is generally more than enough. 30 for a knee is generally more than enough. It's a small number of patients who go through those and then actually need any more. In fact, a large portion, not the majority, but about 40% of our hip replacement patients after the hospital take 0 pain pills. They don't even take 1. So knowing that, we know that other patients shouldn't be taking 40 and 50 and 60 pain pills afterwards. Dental hygiene, this is important because, and this is true for the lifetime of an implant. So if you're going to get a hip or knee replacement, something to know can happen. If you get a bad tooth, and that tooth gets a bad infection, that can go into the bone, and it can go from the bone into the blood and eventually end up into your joint replacement. And that can happen many years after the surgery. So dental hygiene before and after your joint replacement surgery is important. All we require is that you've been going like you've been told every 6 months or so. And if the dentist has said, hey, you really should do this, that you did it. Right? It's not usually a mystery. This isn't really complicated. But sometimes for like you may have Medicare and it covers your hip replacement, but it doesn't cover your dental insurance. It's something important to make sure you get all your teeth taken care of prior to having your joint replacement, and then you keep up with it over time. So non-modifiable risk factors, having a history of a family history of a blood clot makes you at increased risk of having a blood clot. So if you've had a blood clot before, or your brother or sister or mother or father has had a blood clot before, you're at increased risk. And in that case, we're going to treat you a little more aggressively after surgery to try to prevent you from getting a blood clot. So that's a non-modifiable risk factor for blood clot. COPD, so the lung disease that's associated most closely with smoking, that makes it more likely you're going to need a blood clot. If your BMI is over 30, so we're not talking about the limit where we want to do surgery, but simply having obesity, a BMI over 30 increases your risk of blood clot. A history of heart attack or a stroke, history of peripheral vascular disease, which means arterial disease in your legs, or some of these factors in your blood. Factor V Leiden makes you increased risk for getting a blood clot by having that factor in your blood, or if you're missing protein C or you're missing protein S in your blood, then you're more likely to get a blood clot. So these are things we'll search for in your history, talk to you about, and that can affect how we're going to treat you postoperatively. We can't change this, right? Your proteins in your blood, these proteins are genetic, but how knowing about those things can affect how you should be treated afterwards. And again, smoking is going to change things because we won't do it until you stop. Cardiovascular disease, if you've had a heart attack before, we're going to be very cautious about your anesthetics can be a little bit different. Other things can be different, but that, again, non-modifiable, but we want to know that in advance. History of stroke, history of blood flow problems to your lower extremities, heart failure, AFib, if you're a high fall risk, if you become very deconditioned, like your arthritis is so bad you haven't walked in a long time, there are things we need to do differently to make your recovery safer. So those things are the individual things for the patient. Now we're going to talk about things we do for everybody. So once you go to surgery, every single patient is going to get all their best possible treatments to avoid infection. You may have heard of the spacesuits that we wear. We're in surgery. We put these little helmets on, so none of the bacteria on our skin or anything from our breath can get into the air and then end up in the wound. So everybody who's going to be close to the wound is going to be wearing a spacesuit to prevent all the bacteria on that person from getting into the area we're doing surgery. We limit traffic in and out of the operating room. Somebody doesn't need to come in there during the surgery. We don't let them come in because we don't want them to carry in anything in the air that comes in and out of the room or that comes on their clothes. These types of things are pretty uniform. Things that we do that I think not all surgeons are doing, I know not all surgeons are doing, is we actually inject antibiotic right into the joint and the surrounding tissues. So everybody in the United States, I mean, you wouldn't be accredited as a hospital if you didn't give IV antibiotics when you got a hip or knee replacement, but not everybody's injecting the antibiotic right into the tissue, and I think that's a plus, and I think eventually that will become a standard as well. We keep the blood pressure under control. So, not just so high that it doesn't hurt your heart or your brain, but we try to keep the blood pressure low so that you bleed less during the surgery. If you bleed less during the surgery and you leave less blood in the body, there's less food for bacteria to feed on, if you will. It's bleeding that takes place at the site of the surgery is an independent risk factor for infection, so we want to minimize that. When we put retractors in, so these are the retractors. This is a patient's hip, and we're looking down in the hip to do the surgery. And everybody who does hip surgery has to have these retractors, otherwise the tissue would close up, right, and you wouldn't see in there. But what we do to prevent the retractors from damaging the skin is put this protector all around the wound. So think of this like a denim, it's about as thick as a pair of jeans type material that will protect the edges of the skin so they're not traumatized by the retractors or any of the instruments that go in and out of the wound. So in the past, before we had this tissue protector, you might see little dents in the skin where that retractor was pulling on the skin. You might see a scrape on the skin where an instrument bumped up against the skin going in and out of the wound. So the tissue protector helps prevent infection and wound healing problems. Tranexamic acid, we put that in the wound, and it's a procoagulant. Acid sounds scary, but think of it more like ascorbic acid from vitamin C, or it's not caustic. It's just if you put it on a surface of a tissue, it'll help that tissue coagulate. So if you're losing a little tiny bit of blood from the surface of a muscle, you put the tranexamic acid on there, and then the bleeding will stop. I don't know if we have a picture of the perineo. We don't. But perineo is a tape. So after we sew up the hip or the knee, we then seal it with tape. And the tape has the glue in there. If you saw wound glue on television, when that came out, it made a big splash. But they improved that by taking the glue, putting it into like a burlap type material, and that spread across the wound so that bacteria from the outside can't crawl back into the wound as we're waiting for the skin to knit. So we literally seal the wound closed with a tape glue combination called perineo. After the surgery, we place an ACE wrap around the hip to try to, or knee, to try to compress that area and prevent blood from collecting in that area. So just like you want to stop the bleeding, you put a little pressure on it. That helps reduce the bleeding. Reducing the bleeding helps reduce infection. Occasionally, depending on the amount of bleeding, you may have a tube that comes out of the wound, and that tube will pull any excess blood out. The drains, routine use of drains, like doing it every single time, is not as common as it used to be because theoretically that's also a little path the bacteria could work their way back in, right? But if you're bleeding a fair amount and we think that there's going to be some residual bleeding after the surgery is over, we'll leave the tube in there to try to take out any excess blood. The Foley catheter, we generally do use catheters, but as soon as you can stand up, we take it out. In the old days, catheters stayed in overnight, and patients could get an infection from the catheter in their bladder. We give you 3 doses of antibiotic. This is the sort of thing that every hospital in America basically has to do or they'd lose their license. Tight glucose control, very important. So it's not going to be checking your sugars like in the morning and the night. It's probably going to be checking your sugars at the minimum 4 times a day and sometimes every 2 hours if we're concerned that we're not going to be able to keep your glucoses under tight control. This part here, this next part, and this part are not common. Not everybody's doing this yet. I think they will be. The risks, high-risk patients are given antibiotic pills to take after the 24 hours. So this is definitely different from doctor to doctor, but new data in the last couple of years have shown if you're a patient who has diabetes, you're over 70, your BMI is over 40, or you have a kidney or liver disease, you should not just get 24 hours of IV antibiotics, you should probably get another 5 days of oral antibiotics. And some of the data coming out of large centers with tens of thousands of patients to study show this to be quite effective. Postoperative prevention of blood clots. Everybody gets these devices that squeeze your leg so that if there is blood trying to pool in the veins, we're going to squeeze the veins. That blood's going to travel up to your heart before it forms a clot, and that way we can help prevent blood clots. We also put some TED stockings on, which are compressive stockings, and those things are done to try to reduce the risk of blood clot. But probably the most important thing to reduce the risk of blood clot is to get up and walk right away. So if you're moving around and you're being active, your chance of getting a blood clot is very low. And now, generally, we want you to walk within 3 hours of arriving to the floor. So you've woken up in the recovery room, and they take you up to the room. We give the nurses time to check you in, make sure everything's okay, make sure your blood pressure is good. But within that first 3 hours that you get there, we'd like you up walking around. It's not, not that we just want you to be really gung-ho, but by doing that, you keep the circulation in the leg going, and you reduce the risk of a blood clot. So that's probably the most effective way to prevent a blood clot. And then walk often, right? Not just soon, but often. And here at Oakleaf, if a patient gets to the room late, they walk with nursing, but our therapists will try to work with you the day of surgery if you're not too late getting to your room. Post-operative prevention of DVT, this is an area of flux a little bit. We used to use Coumadin in everyone. Then all of Oakleaf tried Xarelto for a while. We had too much bleeding. We all quit using Xarelto. We've kind of gone back to different agents for different doctors right now. But in my practice, if you are at low risk for a blood clot, and we look at all your family history, and we have a sheet that we fill out, and we score you. If you're at low risk for a blood clot, we're going to use aspirin. Now, aspirin isn't as good at preventing blood clots, but it also doesn't cause as much bleeding, which probably helps reduce your risk for infection. So we're okay with backing away a little bit from the intensity of treatment for blood clots in order to reduce the risk of infection. If you're at higher risk, you're going to get Coumadin. And boy, we would love to use the agents that don't require blood checks, whether it's Xarelto or any Eliquis or any of the other ones that are out there. But as we've tried those, we've just had too mmany patients with bleeding, and most of those don't have a reversal agent. So if you start bleeding too much from Xarelto, there's nothing I can give you to stop you from bleeding. There's not an anti-Xarelto out there the way there's an anti-Coumadin treatment. So we've gone back to using Coumadin in those high-risk patients. In conclusion, I think it's easy for patients to understand that surgical complications are a really important factor. I think people who are going into surgery automatically think about that. I think they think about it a lot more than doctors give them credit for or consider. We're really diligent about preventing these complications by discussing the risks with patients prior to surgery and addressing any modifiable risk factors. So if there's something we can do to make the surgery safer ahead of time, we should really do that. We utilize all the measures at our disposal intraoperatively and postoperatively to reduce the risk of complications. We assess your risk for complications such as DVT or PE, and that affects how we treat you afterwards. Joint arthroplasty can have a profound impact, so I don't want people to be scared away from having a joint replacement. It's sometimes the best thing you can possibly do for yourself, but at the same time, we need to do everything we can in our end, and with your help, to make that surgery as safe as humanly possible. We know that at the end of every time you take off for a surgery, there's people waiting for you on the other end. We want you to arrive safely and rejoin your family and your life healthy and restored. So I'm going to take questions standing up here, and then I know patients like to ask questions, people like to ask questions individually afterwards. There'll be time for both. But if you have a question you'd like to share with everybody, feel free to ask questions now. I'll try to repeat the question so we can get it recorded. And then if you have questions you prefer to ask individually, you can come up and ask either myself or Mrs. Nelson afterwards. So go ahead.
You talk knee and hip. Do you do shoulder as well? Is that
the question was, we were talking about knee. This is all about knee and hip.
right.
So the question I'm going to answer had two parts. One, most of this data is all knee and hip because that's more common.
Right.
So a lot of the things I'm presenting we might assume are true for shoulders and elbows and other things that are less common, but they haven't been as well studied. I don't personally do any shoulder surgery, but there's several guys in my group who do. And so to the extent that they are adopting this data, I'm not entirely sure because it wasn't garnered from patients getting shoulder arthroplasty. It's kind of almost embarrassing we didn't have this data when you think about people in smoking since we started doing joint replacements in 1969, right? The first FDA-approved total hip was by Dr. Coventry at the Mayo Clinic, 1969. People were smoking in 1969. The fact that we didn't know how big a risk factor it is because this risk factor is unmeasurable in groups of 200, 300, 400. You need to do a study with tens of thousands of patients to really factor out these risk factors carefully because you're studying an uncommon event. So if the infection rate is base 1%, doubling is only 2%. So to get a statistically significant difference when you're measuring that uncommon an event, you need large groups. And so we never did the large groups. I'm afraid, I don't know this for sure, I'm not sure that there will be a shoulder arthroplasty study that replicates this data. I think probably best practice is if you're a shoulder surgeon and you're doing shoulder replacements, you might borrow this information knowing it's not exactly the same as hip and knee data, but it probably is applicable. So that's a very good question. Glad you brought it up. Any other questions? Yes.
I've read that there are some studies going on trying to use stem cells to be injected into the joints to regenerate cartilage. Is that anything that's going to be in the near future that could avoid this sort of a drastic surgery?
Well, exactly. So let me repeat the question. It was a very good question. The question is about using stem cells to avoid the need for arthroplasty. The arthroplasty we're talking about is artificial parts, right? You're getting a hip or knee made in New Jersey or Indiana. So that is in the news. It's very interesting, right? Because we would love to give you back the hip you had before you had arthritis, right? Your own cells, your own tissue. And so stem cells are generating a lot of interest. There has been waves of interest in trying to get cartilage to heal, whether it's with stem cells or growth factors or different treatments for a long time. I think the jury is somewhat out as to whether they're effective. Now, the hard part with arthritis is, and anybody who has arthritis, you have good days and bad days and good months and bad months. And, it can be hard to know for sure if a treatment's effective unless you do like randomized prospective studies. And so one of the reasons like insurance companies are not covering stem cells is because the data isn't quite solid enough yet to say for sure that these things are making a real positive difference. I'm optimistic because that would be the ideal joint replacement, right? One that has normal, healthy, your cartilage, your cells, your DNA, everything in there. But as to date, the data is somewhat out there. It's the kind of thing I keep reading about because it would be great, right? If we could just take you to an injection suite and inject some of your own cells, and then you did some type of proper physical therapy, and then your cartilage grew back, that would be ideal. But it hasn't worked out to the point where we can show that really works very well. I think as soon as that's definite, people would do it more. But we certainly keep an eye on it. It's a good question. Yeah, so I have seen a number of patients. So I've done a lot of joint replacements on patients who previously have had stem cells. I haven't seen a lot of patients coming to me with like disaster problems from stem cells. So when a patient comes to me in the office and says, I really don't want to get a hip made out of metal and ceramic and plastic. I want my own tissue. I talk to somebody about stem cells. What do you think? I tell them what I told you, which is I'm not sure that it works. But I can also tell them that I haven't been seeing disasters. I'm not getting called the emergency room on the weekend for somebody who got a stem cell injection, now the hip fell apart, or they got an infection, or something horrible happened to them. So I would think if it was a really horrible idea, I would be seeing the flip side, right? I would be seeing these disasters showing up from time to time, and I'm not seeing that. So that's encouraging. And then I tell the patient, I just can't give you solid information. I don't think there's data that makes me confident to recommend it. So, but certainly patients are trying it because who wants a big surgery? We talked about complications, win the shot that makes you better, be better. So, very, very good question and pertinent question a lot of people have. So, and I saw here, question?
I was just going to ask, with knee, is it true that you shouldn't have a total knee too young? Chances of you needing it redone if you live a longer life?
Question. So that's a great question. And that's a very common question. So I'm going to repeat it. The question about doing your arthroplasty, she's asking about knees, but it could be a similar question for hips. Like, do you not want to do it when you're too young so that you don't have to have it redone? So that's a really important question. What has happened over the last 20 years is that question's changed dramatically. When I was first starting in 1992, we wanted you to retire. We wanted to be sure you tried a cane. And, we didn't want to do it if you were under 65, if at all possible, because we were afraid it was going to wear out. There were a couple of reasons. One, the bushing, the plastic wasn't very durable. And if I got an x-ray of somebody 10 years afterwards, I could see the plastic literally wearing down. And if I did a surgery on somebody who's 40, well, when they're 50, it's wearing down. When it's 55, it's worn through. And now I'm doing a second surgery. But if we do the timing and think about the product cycles here for a minute, first FDA-approved total hip, and hips came before knees, 1969 at the Mayo Clinic, and then mid-70s for the first FDA-approved total knees. We were really experimenting all through the 70s into the 80s. We had failures in numbers in the 80s. I can tell you in the 80s and early 90s, revision surgery was unsettled. Like if you came with a failed hip replacement or a failed knee replacement in 1995 and you came to see me, I would say, this is what we're going to do to make it better. I can't tell you what the 10-year results are because we've only been doing this for a few years. So the prospect of a second surgery was daunting, right? You hated to start the ball rolling not knowing what was going to happen when you inevitably knew it was going to wear out. So we've gotten a much better bushing now. So when I take an x-ray at 10 years, there is no change in the bushing. I can't even see it wearing out at all, let alone wearing thin. It's literally not wearing at all. And now if you come to see me, it turns out that a lot of the techniques we developed in the 1990s, by 2005, 2010, I could tell you, redo surgeries are effective and durable. So our fear of that second surgery has really gone down. Our belief in the durability of the initial implant's gone up. So what is an old person for arthroplasty really shifted. I have no qualms now with somebody in their 40s, late 40s, and early 50s getting a replacement. I think the chance of them getting a second surgery is low. And if even with today's technology, when they get a second surgery, we could do it today. The second surgery could be very predictable with a good result with durability. So we've transitioned in 10, 15 years from a great fear of the second surgery and things wearing out to much more durable implants and second surgeries that are reliable. So it's changed that calculus quite a bit. That's a great question. A lot of people are interested in that.
To go along with the age question, can you talk a little bit about assuming arthritis, the arthroscopic surgery, cleanup of the joint versus total joint replacement, and maybe how that decision is made?
That's a good question, too. Another question, so let me repeat it. The question is, if somebody comes in with a joint problem, hip problem or knee problem, how do we decide if they're a candidate for an arthroscopic surgery where we make the small incisions and can take out damaged cartilage and kind of repair things with small instruments through small incisions without putting anything back in. So that would be an arthroscopic surgery versus doing arthroplasty where we cut the joint open and put in an artificial part. So what are the decision-making things? So the arthroscopic surgery is limited, that it doesn't put anything back. And so in some sense, it's like no matter how many times you cut it, it's still too short, right? If you don't have much cartilage left, the arthroscopic surgery can't make it much better. It's just removing things. My best analogy I use for patients who are looking at an arthroscopic surgery, it's like taking an old gearbox with loose teeth, and you open up that gearbox and you wash out the loose teeth and you put it back together. We have an old gearbox with no, the teeth are gone. They're not getting caught in the middle of the gearbox, but you still don't have a new good gearbox. And sometimes when you put it back together, it doesn't work at all, right? And sometimes it works for a while, but it's still not a new gearbox, and more teeth can break free and things can wear down. So probably there's not one more controversial thing among doctors. So if you came to a doctor with a torn meniscus and moderate arthritis in your knee, you can go to different surgeons and get definitely different answers. So that's somewhat controversial. I like to tell you what I think and then what people think in general, so you can know that the difference between opinion and fact. My opinion is that when I look at the data, most meniscal tears should be treated conservatively in people over 40, unless they have profound mechanical symptoms. So if your knee is popping and catching and you really can feel that loose tooth in the gearbox, then you might benefit from an arthroscopic surgery. But if you have just some pain, some achiness, occasional sharp pain, but it's not real mechanical in nature, you're probably better off with physical therapy, an exercise bicycle, activity modification, and not having an arthroscopic meniscectomy. So that's my take on it. You can find surgeons who are more aggressive in taking out damaged menisci, and I would say I'm on the conservative spectrum there. But I think as more and more data comes out, 6 weeks of an exercise bike or 6 weeks of physical therapy is awfully close, if not equal, to arthroscopic surgery in a lot of cases. So we tend to go conservatively and wait until we absolutely have to do a scope, or if things are getting worse, cortisone injections, a little more time, and then do a definitive surgery where they get an arthroplasty and they're not going to have that second surgery. One of the reasons it's controversial is what's success. Let's say you came to me and I did a knee scope and I do your knee replacement a year later or 2 years later. Was that a successful surgery? Somebody might say, look, I got a scope and I put my knee replacement off 2 years. Another person would say, look, you had 2 operations within 2 years. What, was that really worth it or not? So some of these are judgment calls, and how hard is it to go through the scope, and how comfortable are you with an operation that's somewhat unreliable? I would say knee arthroscopy when there's some arthritis there is unreliable. So those are things that you need to discuss and individualize. But I can tell you that a lot of things in orthopedics are not controversial. That is, you could go to 5 different guys and get 2 or 3 different answers if you have a torn meniscus and a knee that has some arthritis in it. So I don't know if that answers your question or just makes it more confusing, but at least you know where I stand on it. Yes.
If you need both knees replaced, what are your feelings about having them done at the same time?
So this is a great question too. The question of if you have two knees that are both arthritic, and let's assume they're both severely arthritic, they both bother you a lot, right? You never want to do one just because you're doing the other one. But if you have two knees and they're both really bad and you feel like both of them need surgery, should you do them at the same time, or should you do one and then wait and do another one later? So the data on that has been collected over a number of years because it's a pretty easy study actually to do. So institutions will say, we're going to randomize people, and people are fairly willing to do that in that situation. Like, I'm going to do one, I'm going to do them one at a time. It turns out that with fairly selective guidelines, so if you have no risk factors, you're generally younger, you're generally healthy, it is safe to do them both at the same time. It is probably more arduous. So I tell patients that we can do this. You're not more likely to get infection. You're not more likely to have a blood clot, a heart attack, or a stroke. But it is going to be a harder road. It's going to be a little bit more difficult. The first 2, 3, 4 weeks are definitely more difficult. If you have risk factors, it's probably, not probably, if you have enough risk factors, doing them both at the same time is not a good idea. You increase your risk of needing a transfusion. You increase your risk of having medical problems. Increase your risk of having to go back for what's called manipulation. So in select patients, it's reasonable. In not everybody is it reasonable. But I would tell most patients, if you're not under some type of social pressure to get back immediately, like, I have people who say, I can afford to be off work 8 weeks, but I can't afford to be off 2 8-week periods. I'm going to, go bankrupt. It's too much money. I can't do it. Those patients, I would say, I do two of them at the same time. If you're a patient and say, well, I have the time, I would recommend you do them one at a time. That's the answer I give to most patients. Do I do them both at the same time? I do. And we actually do both hips at the same time as well occasionally. So that's possible. The discussion is very similar to the one I had about the knees. So having both hips done at the same time, as long as you go through what's called the anterior approach, which is beyond the scope of this talk, but it's a less invasive way of doing the hip replacement. We've done a fairly large number of patients now, both hips at the same time, and they've done well in selected patients with no risk factors. So, good.
In regard to that same thing, if you had bone on both knees, would your answer be the same that you just gave in terms of doing it? And also, if you were over 80, would that have something to do with it?
So again, the question about doing both at the same time, I would think if you're over 80, I would say you should do them one at a time. I think the age is probably somewhere between 60 and 70, where you're probably going over the threshold of where it's a good idea to do both at the same time. Could you do it? Probably, but would it be in your best interest? Probably not. In fact, there was a good study on two knees in the same patient over 80 and at the same time, and that there was a much increased risk of complication. And those were patients over 80 with no other medical risk factors, right? They hadn't had heart attacks, they hadn't had strokes, they didn't have diabetes, and yet just being over 80 puts a little more strain on you. So, one at a time would be my recommendation. Probably that transition for me takes place by about 70. So, good question. Any other questions that you want answered? No? Well, we're going to stay around and answer questions individually if you'd like. And I appreciate your attention, and thanks for coming out on a nice spring day and hearing about arthroplasty.
Thank you.
You're welcome.